Fab. Okay, so we're starting this session with paediatric history taking, just so everyone is comfortable with PEDS history, and this is something that is assessed a lot in OSCEs. So before we do that, we'll cover some core terminology in PEDS, because as a lot of you said, you're sort of not understanding what's going on. There's lots to sort of, it's overwhelming, but I think once you understand some core terms, understand the sort of basic process of things, it'll start to feel a little bit more achievable and sort of more understandable. We'll also talk about how to take a pediatric history, focusing on the extra bits. I know that you're able to do a Socrates. I won't labour that point. We'll just talk about the bits that are relevant to PEDS, or the extra bits that you might not have covered before. We'll talk very briefly about what is normal, because I think that's something that people struggle with a lot in PEDS, and I'm not sure we'll be able to put it in practice. We'll see. This is a very core introductory lecture about all things PEDS. So I'll use the PEDS history to sort of highlight certain points, for example, development or immunisations and things, just so there'll be useful slides for you to check back, but we won't cover things in too much detail. We're trying to use VVox this year, so we're doing interactions through that. I might not be as attentive to the chat. I'm on 2 screens at the moment, which is why you'll see me doing this a lot. But yeah, if there are questions that I haven't answered, please pop up on the mic, or Issi can help and let me know, and we'll make sure that the questions are answered. But yes, so first of all, I think PEDS for me had a lot of terminology that I didn't understand. And apologies if this is basic for some, but I know I was the younger brother, I didn't have a babysitter. So a lot of this was new to me. So I think before we dive into it, let's talk about some terminology. So for everyone in the chat, if you whack in a term that you're familiar with and try and define it for me, put it in the MS Teams chat and we'll see. But yeah, one of the key things I found sort of important to differentiate is the term infant and neonate. So if anyone can define that for me, but anything else on the screen, if you know it, put it on. Meconium, fantastic, Jordan. It is the very first poo that a baby has. And the reason why we ask about it in a history is because sometimes babies have a bit of a delayed meconium. We usually expect most babies, like 98% of babies, to pass their meconium in the first 24 hours. If they haven't passed it in 48 hours, that's when we start to worry and we investigate certain causes. Fantastic, Sylvia and Esme. NICU is the neonatal intensive care unit, and SCIBU, the special care baby unit. We'll talk about those terms slightly later on in the talk. But one of you, Anoja, has defined it very well already. It's basically ITU, but less in SCIBU. Neonate, very good, is the first 28 days. So can anyone guess what infant means then? APGAR, very good, is a scoring system. We'll talk about that later. Post 28 days. So not quite, Jordan, it's a very good guess. So neonate refers to a baby in the first 28 days of life. Infant is a baby in the first year of life. So any baby that's a year or younger is an infant, but specifically in the neonate is when they're 4 weeks or less. And the reason why we have a separate term for 4 weeks or less is because neonates who are younger are more vulnerable to certain things like infections. So you'll hear the term neonatal sepsis thrown about a lot. But very good. You clearly have a better knowledge of the terms than I did when I started PEDS, so that's really encouraging. Sorry, so an infant is someone who's older than an infant is any baby less than a year old. So 6 months old is an infant, 8 months old is an infant. When you get to 1 year and above, that's something else. Sorry, I didn't define that very well. But a neonate is also an infant. Great, good questions. We'll talk about teething and clotting later. Very good. Before we go on, those were some of the terms that I thought. Are there any other PEDS terms that you've seen bounded about that you'd like explained or you'd like us to discuss? If not, just put no, so I know that there isn't anything else for us to talk through. I'll wait for a few more of you to respond. Like I said, if there's no other terms that you'd like me to talk through, just whack in no. Okay, so 10 of you on VVox, 2 of you have very kindly responded. If I get a few more responses, even if it's the word no, because there's no other terms that you want us to talk through, that'll be helpful. I'll wait till we get half of us. Great, okay. I've just closed the poll. If there are words that aren't here that you'd like to find, just pop. Okay, perfect. Right, that's good. But if there are terms that pop up, pop them in the chat. Right, so here is your core history. You've got past, presenting complaint, history. I'm not going to go through this, you know it. But with a paediatric history, there are a few extra bits. I like to think of them as within these main headings, just so I have a sort of structure for them and I'm less likely to miss it. So in a history of presenting complaint, as always, you would do a systematics review, but here in PAEDS, there's a specific paediatric systems review that I'd encourage you to do. Within the past medical history, because often you're talking about babies who don't really have many medical conditions, there'll be less on that, but there'll be more on these things. So the birth history, screening tests, how they're developing and their growth. Don't ever forget growth, it's really important. Drug history, you'll talk about immunizations, often they won't be taking drugs. Family history, don't forget consanguinity. I know it's a bit of an awkward one to ask about in a history, and often it doesn't feel relevant, but it is worth asking. Actually, I got docked marks in my year 5 OSCEs because I didn't mention it, and I didn't feel like it was a presentation where it was particularly relevant. So just get used to asking. Social history, really, really important to ask about domestic abuse and also whether there's any social services involvement. As always, ICE. I put heads assessment in brackets there. Does anyone know what a heads assessment is? Or sort of what domain of paediatrics we might be using a heads assessment? What kind of ages? Fantastic, John. Yeah, we do it on adolescents. And the idea is when you speak to moody teenagers, they might not want to open up to you as a doctor. So we go through the heads assessment as a nice structured way of getting them to sort of get used to you, be a bit more relaxed with you. So the heads assessment starts with easy things to talk about, life at home, what's school like, and then it gets on at the end to talk about the things that they might not be willing to speak about unless you'd open them up first. Things like drugs, sex, that kind of thing. Okay. We won't talk about heads assessment here. We can talk about it another day if people are interested. It is an important history though. Again, that was in our OSCEs. So before we even get to doing our history, it's important you start off the consultation right. So the thing about children is you need to really work at building rapport with them. I think everyone in an OSCE will be like, oh, I like your shirt, or that's really cool, would you like a sticker, that kind of thing. Like, treat the child with respect, speak to them first because they're the patient, and then get on with the rest of it. Always worth establishing their relationship to the adult in an open way. So don't go, are you mum, are you dad? Because you will make unfortunate mistakes and that will already set you off at a bad start. A thing I like to do is if there's a kid that's coming in with their parents, I'll ask the kid, who have you brought in today? And the adult usually answers. But again, you're speaking to the child first, you're giving them the power because they've brought their responsible adult, and you'll find out in a nice open way. We will talk about consanguinity later on, but I think Izzy has answered it very well already. Exactly. Speak to the patient first. They can give good histories and they know what is going on better than their parents. But if they are too young, you can, again, before speaking to the parents, ask the child, can I speak to your mum or can I speak to your guardian about that a little bit more? And I'll usually say yes. With teenagers, you might often ask to speak to the teenager alone because some of the things about their health they might not want to reveal in front of their parents. So how might you ask a parent whether you'd be able to speak to their child alone? Do you know any stock phrases or anything that you try and say instead? And pop that in the Teams chat rather than the word counts. I know, again, it's a bit of an awkward one, but it's good practice to ask it, and you can definitely phrase it in a way that's not like, oh, get out of the room. And yeah, that's very good, very professional. Would you be okay to step out for a few minutes while I speak to your child? Very good. 99% of the time, their child will say, the parent will say, yeah, that's fine. What I quite like to do as well is sort of give a justification and try to explain why we want it. That's also very good. Our usual practice, very good. So sometimes if you say, would you be okay? What are you going to do if the parent says no? If you put in something like our usual practice or it's trust policy, that sort of thing, it makes it seem a little bit more resolute. And it means that they can't be angry with you, but they can be angry with the trust policy instead. Similar thing I would say when you're talking about chaperone. So it's trust policy to have a chaperone present. Is it okay if they're here? Oh, sorry, is it better for them to be next to you to support you or next to me? And that way that you're giving them a choice, but the choice is where they are in the room, not whether they are in the room or not. I often say as well, it's trust policy to allow adolescents to speak initially alone, to empower them to be more confident with their health or to be more responsible of their own health. Is that all? So again, we're giving a justification, but very good responses. So that's in starting it off. Then you do presenting complaint, do your usual history of presenting complaint, throw in a Socrates, and then you do your paediatric systems review. I think this can be quite a daunting one, but I think it's very easy. Just break it down into this. What do babies do? Whack that in the MS Teams, okay? What do babies do? I had a paediatric consultant, I won't name their name, who says babies are incredibly boring because they only do a few things. Good, cry, eat and drink, very good. Anything else? Poo, vomit, good, very, very good, very extensive. Babies are boring because they only do these things, and grow, that's a very good one. I haven't actually put that on my slides. So, babies poo and pee, so ask about wet nappies. They feed, so ask how they're feeding. So are they breastfeeding, are they bottle feeding, is it a bit of both? Make sure you don't shame parents in how they're feeding their child. They sleep, behavior, so whether they're moving or crawling or sleeping, and their vomit. So important when you're asking about vomit. So there's a thing called posseting, which you saw on the sort of slide terms, and that's basically when babies just spit up a little bit of milk that they've just had after a meal. That's very normal because their diet is entirely liquid. It's normal for you to have a little bit of reflux at the end. But as you can see in the GIF there, that's probably a bit too much. So if it's anything a bit more forceful, anything larger volumes than a mouthful, that's when we think there might be something else going on. Make sure to ask the colour. Why have I bolded colour? Why do we think we're why do you think it's really important we asked about the colour of the vomit? I'm glad you enjoyed the GIF, Sylvia. There are more to come. Indicates contents, very good. But there's one particular that would make me sort of reach blood, good. There's another colour that would make me reach for the bleep for the paediatric surgeons. You'll hear the term bilious vomiting. Very good, Lubna. So bilious vomiting, so vomit that is very green, suggests that there's bile in, which means there's an obstruction lower down. And usually in babies, that suggests a more sort of important cause, like Hirschsprung or I've forgotten the term now, necrotizing enterocolitis can give you that, volvulus, anything like that, which requires sort of immediate surgical attention. So good, ask about the colour if they are vomiting. Okay, so on top of what babies normally do, for your systematic review, you'll also want to establish red flags. Can anyone guess the two main red flags I tend to worry about in a paediatric history? One that you would usually ask in an adult history anyway. Actually, both you tend to ask about in an adult history. Good, both of you have captured it, very well done. So fever, really important. And B symptoms, less so. I mean, you cover it when you're talking about growth in terms of weight loss. Night sweats isn't quite a thing in babies, but definitely fever, but also signs of respiratory distress. So an important tidbit for you to know is that of cardiac arrests in PAEDS, most 90% down to respiratory distress. So we really, really worry about that. They're also particularly prone to respiratory infections. So you want to cover both fever and signs of respiratory distress. So important when they say that they've got their darling child that has a temperature or has a fever, you need to ask, have you measured it? What have you measured it with? Sometimes they'll just be like, oh, it just felt hot. You want an actual number, really. So if it just feels hot, you can't really take that to be a definite sign of a fever. Most parents actually now are very well equipped and have a temperature thermometer kind of thing, and you can measure an ED anyway. Important to figure out how high it gets and whether there's any patterns or whether it's helped by paracetamol. So these are some GIFs of respiratory distress. If anyone can name them, so again, take your pick, see if you can find them, tell me which one you're talking about and what sign you're seeing, but these are ones to look out for. Very good, nasal flaring on the top left, fantastic, Sylvia. Yeah, the fourth one doesn't I couldn't find an MP3 of the sound, but can you think of a sound that's especially associated with respiratory distress? And then any others. Stridor, that's good. That is linked to a very specific respiratory presentation. In terms of respiratory distress, there's another particular sound that you're worried about, but very good. I would also be worried if I heard stridor, so that's good. Wheeze, similar. Again, it's linked to a specific respiratory condition, less so with respiratory distress, i.e. the baby is really, really suffering to oxygenate their blood. It's grunting. So grunting, you might hear it. I haven't got the sound here, but and I'm not very good at imitating it. But it's kind of like a, and it's rhythmic on every time they're trying to breathe in, and it's their way of trying to put pressure in their lungs to keep them open. So grunting is not a sound you want to hear. Any of the other gifts people want to have a go at, or shall I move on? Okay, for interest and time, I will move on. So we've got nasal flaring. The one to the right of that is head bobbing. You can see the baby sort of doing that with its head. And the reason why is just like adults using our accessory muscles to help our lungs open up, babies do the same, except babies' necks aren't so rigid. So instead of it staying still and our lungs getting bigger, babies' heads are bobbing from the use of the sternocleidomastoids in the scalenes. Okay. For the bottom left one, you can see there's gaps between the ribs, okay, on breathing, and that's intercostal recessions. And again, that's accessory muscle use. It's the use of the intercostal muscles. So if you ever see gaps between the ribs and a clinical picture of a baby that's unwell, very, very bad sign. We talked about grunting, which is what the babies do to try and keep their lungs open to increase the PEEP. And then the one to the furthest on the right is the most subtle. And you can look with the eye of faith, you can see the sort of trachea is pulling up every time the baby's breathing, and that's called tracheal tug. So I wouldn't extensively ask about every one of these in the history. This was more just as a diversion, so you know the signs of respiratory distress. I would tend to say, oh, when your baby's been breathing, have you seen their sort of a gap between their ribs, or have you seen their flaring of their nostrils? And then that's usually enough. Okay. So paediatric systems review is what do babies do? So poo, pee, feed, behavior, and vomit. Plus your red flags, so fever and respiratory distress. But I think what people tend to struggle with is knowing what's normal, particularly if you haven't had any younger brothers or been babysitting for babies. So we'll do this quiz. What is normal, most normal for a healthy neonate? I'm afraid this one isn't a VBOP, so just whack it in the chat. I'm sorry for the graphic pictures. Okay, so we've got one taker on B. Anyone else want to agree or disagree or just throw your options in? Another B? Okay, very good. Lots of you going down this wave of going for B, but are you right? We will see. You are indeed all correct. So A, you would not expect a neonate in their first 4 weeks of life to be having such solid poops. And the reason why is because think about what they are having to eat. They are drinking an entirely liquid diet. So it will be very loose, pasty stools. C, you can see the redness. It's not blood. It's urate crystals that crystallize in the nappy. That can be normal. It's actually to do with, it can be normal in kids, particularly if they're dehydrated. So if they're dehydrated, they're producing very concentrated urine, so the urate will crystallize and leave red nappy. But again, in the world of SBAs, most normal is B, a very loose, pasty stool. It's often described as chicken curry-esque. Sorry if any of you are having a takeaway tonight, but yeah, chicken curry coloured, loose, pasty stools is very normal for a neonate, given their diet is pretty much liquid. And beyond what looks normal, I think I always struggled with normal number of wet nappies, what's the normal frequency and duration of feeds, all of these questions, but you don't need to worry about that because you have one simple question that you can ask the parent, which is what is normal for them, okay? So you can ask a parent, how many wet nappies have you had today? Okay, you've had 3 wet nappies today. What's normal for them? You know, a week ago, how many were they producing? And you can assess a difference between them. That's useful to you because it means you don't have to remember everything, but it's also important because babies do vary. So we worry about change. There are some ones that's useful to know. So I think the 2 things that I remember to know is that babies should, in the neonate sort of period, they should be waking up for feeds, and they should be sort of feeding every 3 to 4 hours. Okay. In terms of duration of feeds, that can vary quite a lot, from 15 minutes to longer, and if the baby's falling asleep in between them, that's fine. But they tend to want to feed every 3 to 4 hours, and if they're not waking up by themselves for feeds, maybe there's something going. But otherwise, ask the parents what's normal for them and compare yourself. So that's the paediatric systems review. Moving on to past medical history. Again, these following slides are more extensive than you would ask in a history, but this is for you to look back to later to give you a grounding in PAEDS. So birth history, you want to talk about antenatal checks. So ultrasound scans, you'll have 2 scans during the pregnancy usually. There may be some blood tests, you may do some down screening tests and things like that. Method of delivery, you'll often see the term SVD in notes. Can anyone guess what SVD stands for? Any of you on Mod B? Very good. Spontaneous vaginal delivery, i.e. they gave birth not through cesarean section. It was spontaneous, i.e. it happened without them needing to be induced or us helping the pregnancy go along. So that's kind of the most normal one. Okay, so spontaneous vaginal delivery. And then APGAR scores. So you do APGAR scores, which assess the babies on 5 domains. I won't go into them now because it's not too important. It's out of 10. And we do that at 1 minute after birth, 5 minutes after birth, and 10 minutes after birth. We use APGAR scores to help us decide whether to help the baby with their breathing and things like that. But the most important one for you to know is the 10-minute APGAR score, because 1 and 5 minutes has no bearing on sort of mortality or how baby is doing. The 10-minute one is more useful. And we talked about NICU and SCIVU already. So neonatal intensive care unit, if they're ventilated, they'll be in NICU. Special care baby unit is sort of a step down. It's kind of like the baby equivalent of high dependency unit, but it's always important to ask in your birth histories, did the baby need to stay in NICU or SCIVU at all? Screening tests, again, this is for you to look back later. I would just say everything okay with the screening tests in the history, but these are the things that they might do. NIPE, you do at 72 hours after birth. That can be done in the community, and then the second one is done at 6 to 8 weeks. And we'll do another talk on NIPEs, which is just a systematic overview of everything from that the babies will have, so top to toe assessment. And that will usually help us pick out some congenital things that we can have to. The neonatal heel prick test is done on day 5, and it's just a heel prick test for a couple of drops of blood, and we screen for common conditions. So we screen for sickle cell, cystic fibrosis, and other metabolic diseases. There's a whole list of them that you should know roughly about, but nothing too much detail. And then you do the hearing test as well, which is done usually in the first 4 to 5 weeks. If the hearing test comes back with some sort of not definitive results, or you're worried about it, then you would send them for brainstem, auditory brainstem response testing. That's kind of the second line. Just put in the top right corner about the principles of screening. This comes up dotted during the year, so you'll also look at it with screening for cancer and things. And it's sort of a CPP topic to be familiar with. So what are the essentials for a screening program, that kind of thing. Development and growth history is a whole kind of avenue of its own, which we'll cover in another lecture. But for the purpose of history taking and in your OSCEs, you just need to ask 2 questions. Are you concerned at all about your child's development? Are they hitting their milestones? But more importantly, have they lost any of their milestones? So if a baby loses a milestone, that suggests regression, and that suggests something pathological going on. Growth, you would just, you can ask, are you happy with how baby's growing? Have they lost any weight? And you would measure that anyway and put it on a chart. How much weight loss is acceptable in the first week? So in the first week of life, babies can sometimes lose weight. Does anyone know the cutoff for when we would be like, oh, okay, maybe we should intervene or we should refer to a clinic? Very good, Jessica, 10%, fantastic. The reason why is babies lose some water weight once they've come out of the womb. Anything more than 10%, we could refer them to feeding clinics and things like that. But anything under is fine. So that's that. Drug history, immunization history. So this is the immunization schedule sort of for the first year of life. Everyone always worries about learning every single one. Just know when they happen. So 8 weeks, 12 weeks, 16 weeks, and then sort of boosters at 1 year old. I found it helpful to learn them just because GPs sometimes like quizzing about them, but it's not imperative for your exams. Okay. The other thing to say is that they often do the baby check at 8 weeks so they can give the immunization in the first time. Okay, worth then foreknowing, if they're not getting any immunisations until 8 weeks, if you've got a neonate coming in, there's no point asking whether they've had any vaccines, or they sometimes get vaccines at birth, so still worth asking actually. But even then, you can say, how are you feeling about vaccines? Because we're always about health promotion. So any opportunity to discuss vaccines and whether parents are particularly anxious or worried about things, especially in the current climate, we should address them. So give them the opportunity. Here is these 3 things, things that people often find quite difficult. So consanguinity, domestic abuse, social services. They are not difficult questions, they are routine questions, okay? So just ask them every time. So Izzy spoiled it for me, she's already put in the perfect answer. So for consanguinity, before you had your child, were you in any way related? So I think that sometimes helps go over language barriers as well, if you just say, oh, were there any relations between you? Domestic abuse, you can simply screen it with sort of, do you feel safe at home? Even if they say yes, but they don't seem particularly confident, that's a cue for you to probe further. Just because they say yes doesn't mean you turn your sort of domestic abuse hat off. Social services involvement, there's a number of ways you can say this. You could just say any social services involvement, question we ask everyone. But I quite like, do you have a social worker? Because if they do, they know it, they will say, and then that will lead you on to taking down the social worker's name and number. Okay. What's really important is you do that, because unfortunately social service documentation in the NHS system isn't integrated, so you do need to find that out. There's no easy way. Finally, but not least, ICE. I actually ICE quite early on, sort of when I'm taking the presenting complaint, just because in an OSCE situation, the parents will lead you to the more important points, but also just generally in life, it shows that you're taking them seriously. It means you're respecting them and involving them in this conversation, which is really important. The weird thing about PAEDS is there's often this 3-way history taking where you're speaking to the kid, but you've also got to deal with the parents as well. So icing them early really helps. But also bear in mind that, you've got dad reflexes here shown by these gifts, and mum reflexes in the bottom left. Trust parents' intuition. If they feel like something's not right for their child, if something's different, do look into it, okay? So take them seriously. Okay, so that's pretty much a paediatric history, all right? I know I covered a lot here, but bear in mind that a lot of these slides was for you to look at later on, just for a bit of a grounding. You can run through them very quickly, actually. So systems review, any wet nappies, any vomiting, how's their sleep, how they're growing, fevers, any fevers measured, and then any problems with their breathing, any gaps between their ribs when they're breathing, any head bobbing. Past medical history, how was their birth? Any problems in your antenatal checks? Everything okay with screening? How are they growing? Happy with the milestones? Fine. Immunisations, is baby up to date with immunisations? Family history, before you were in any way related, before you had your child or before you were married, were you in any way related? Do you feel safe at home? Do you have a named social worker? There you go. Okay, so you'll get very, very comfortable going through this, but I really, really encourage you to stress the importance of asking these routine questions, just because you won't be like me and forget to ask one of those in an OSCE station, but also because it's incredibly important. Okay, you as a medical student can find out things that doctors don't get. Okay, so when it comes to safeguarding and it comes to things that you also don't feel that something is right, trust your intuition and escalate, and because people can fall through gaps, and we can help stop that. All right. I covered through a lot of things. The slides will be available, and I put notes in of everything we've discussed with the answers to the questions. But is there anything else that people want to look at before we go on to done? I will take the stony silence as a no. But yes, please give us feedback. Tell us what you disliked, so we can improve. Tell us what you like, so we can do more of the same. Scan the QR code, but Izzy will also have a feedback slide, so we can do it all at the end.
Do they need to know any embryology for PAEDS?
No, I remember the core. There's that introductory lecture where they're like, "Oh yeah, you need to really know your embryology for your PAEDS." And
no,
don't worry about that at all.
I think just know the whole first trimester neural tube defect kind of folic acid window. I think that's about it.
Yeah.
I don't think it comes up really at all.
The only other condition I think it happens in is sort of malrotation and stuff, but you don't even need to know about the embryology of that. You just need to know that sometimes the gut doesn't rotate normally.
And there won't be any of that Sonic Hedgehog messaging nonsense, so don't worry.
Do not worry.
Okay, so James has control of my slides, so I'm going to be a bit of a Chris Whitty today. So I'm doing a bit of a crossover between dermatology and general practice. A lot of you in the previous session were kind of asking about what you need to know for GP. So I'm kind of just going to briefly go through a few things that I think are quite helpful. So I think people get quite overwhelmed that they need to know fourth year. And I'd say that keeping up to date with as much fourth year as possible is helpful for final year. But I think for fifth year, it's your really bread and butter stuff, your really, really common stuff, and what will present realistically in general practice. And so things like knowing the hypertension medication ladder, knowing, kind of acute confusion in the elderly, just a few common things in infectious disease, like pneumonias, will be helpful, but you can kind of leave your like tropical diseases, your kind of more complex renal stuff and etc. to the side. If we go to the next one, for year 5, it's very, very cross module. So I think in every module that you have, I'd recommend just going over what you might see in a GP setting and also what you can do in a GP setting. The key difference really between year 4 and year 5 is going to be that the management is something you're expected to know, or at least know where you would go to find it. And so for paediatrics, for example, they do lots of 6-week baby checks there, and they'll see how mum's doing. And so I think just know those things as you go through. They're quite big on the cancer 2-week wait pathways. But as you can see, a lot of it is the kind of very bread and butter, very simple stuff. And they also love these for OSCEs. So, like we had an incontinence presentation. And so those are going to be quite high yield topics for you guys. Okay, and then here's a few resources. So people were also asking about stuff. So Anoush last year did a really good dermatology one, which I just don't think I can beat. It's very, very systematic, goes over a lot of stuff. And I think we'll do further dermatology teaching, but if you want quite a good overview, he's got one. And then I think the big thing for dermatology is to look at lots of images of the same thing. In exams, we've had it where they've just shown us a very small photo of a rash and asked you what you think it will be. And I think the only way really to do that is just look at something on lots of skin tones in lots of scenarios. Don't just look at the most severe type of, presentation of psoriasis. Just make sure you know what the smaller lesions look like as well. And then there's a few books for people that like books, and the Zero to Finals Medicine podcast is quite a nice one to listen to on your commute. Okay, so the key differences and similarities to year 4, I've already said that a lot of it is to do with the management now rather than just the presentation and the history taking. Again, for GP, it's really focused on what you're going to do in primary care. So saying you're going to do an MRI is not really what they'll want. It will be going from the most simple stuff you can do, so your history, your examination, then through to bloods, maybe an ECG, and then when you're thinking about referring to secondary care. And so it's good to have that structure when you present as well. So from there on, we'll move on. So this is a little bit of a pediatric crossover. So Mrs. Fowler brings in her 4-year-old daughter Babs into the practice with a rash. So guys, what would be the most important questions to ask in the history? So if you pop those into the MS Teams chat. So, she's got her daughter, she's a bit upset. She's not having the best day with her rash. So what might we ask her? Yeah, good. So when did it start? I think is always a good question. Is when did it start? Did it start today? Did it start 4 months ago? That kind of gives you an indication of, might give you an indication of severity as well. So yeah, is it itchy, which is good. So in Babs's case, it's very, very itchy. The distribution is like something I'll definitely talk about. And yeah, if anyone has been sick around them, And yeah, so the spread is the key thing with rashes. It's always good to ask, because there are certain things that will spread in a certain way. So that's good to ask. And then yeah, ice them. So ask her worries and her concerns. Have they had it before is a good one, which I just don't think I wrote down. And yeah, has it changed over time? So these are all really good questions. So for Babs, it's come on sort of over a day. She had it for about a day, came on over 12 hours, started on her chest, and then spread to her face and her limbs. It's incredibly itchy. And obviously for a child, she's going to be very, very upset. And it looks to mum like it's blisters. And yeah, has she got any other symptoms? So she's short of breath, is she feverish? So in her case, she is, and she's also a bit snotty and she's sneezing. And mum has also said that there's something going around school at this point as well. So okay, we're going to move. We've called Babs in. We're looking at her rash. And so on Vivox, you can just I think it just allows you to enter one word at a time. So just give me some descriptors for this rash, and it doesn't have to be anything formal or specific, but like, how does this rash look to you? And then James, I might need you to
yeah, of course. I'll let you know when we've got more coming through. We've just got 3 responses out of 7, so it's doing well. If we can get a bit more from people, that'd be great.
And so obviously in this one you can't see where it is, but it's always good to start off with where it is. So is it on the arm, is it on the leg, the chest? That's always a good thing to kind of ground you. I think this one is probably on the chest.
Okay, I've just closed the poll. It should show it in a second.
Fantastic. So we've got raised. That's good. So it's always good to say is something flat, is something raised. Yeah, blistered, crusty, patches, vesicular is another good word. So yeah, I think we can move on. These are all good. These are all good descriptors. So I think for dermatologists, the big things they like: location, raised or not raised, one or multiple lesions, color. And so what are the 2 words to describe if something's a flat lesion or a raised lesion? Because this is kind of the language you should be using, really, rather than raised or flat. So yeah, macular is flat lesions. And then what is it when it's raised? And sometimes it's like combined to be like flat and raised. So yeah, papules, the raised lesions. So you can sometimes get a maculopapular rash if there's a combination of the 2. And so we said that her mum said it looked like blisters. And so there's kind of 2 big main words to describe blister-like lesions, and it's depending on the size. So if the size is under a centimetre, what do we call them? And what would we call them if they were over a centimetre? So if they were these really big blisters. Yeah, so under a centimetre is a vesicle. So in this case, we can probably surmise that this is like vesicular. Does anyone know? Exciting, I can teach you, don't worry. So if it's over a centimetre, they call it like bullae or bullous. So it's just a bigger one, basically. So in the Microsoft Teams chat, I might have given it away with my naming of the child and her mum, but can anyone give me like a diagnosis for this? And the film that I was that the 2 people are from, because I thought I was having a bit of a mad one, really. So you've got a child comes in sick. Yeah, chicken pox. Brilliant. Yeah. So I was sort of hinting at chicken run, really, with Babs and Fowler, but maybe I'm just a bit obsessed. So yeah, so this is varicella zoster infection. And so varicella zoster is an alpha herpes virus that is responsible for both chickenpox and shingles. what is shingles? Like how is it different to chickenpox? Does anyone know? Yeah, so chickenpox is when someone first comes into contact with varicella and they get the widespread rash, and it's usually in kids and they recover. Whereas shingles is a reactivation of, so the herpes virus basically sits latently in the dorsal root ganglion, and then it reactivates and it goes along in a sort of dermatomal distribution. So if you get anyone with that sort of rash, can be incredibly painful for patients, and the pain can occur before the rash starts as well. Then you're thinking about shingles. And so the bottom left image is shingles. And so, yeah, the primary infection is usually under 10s. It's a more serious infection in adults. We really do worry about adults who haven't had chickenpox as kids, because it's associated with greater complications. And so chickenpox itself is usually spread by the sneezing, airborne spread. So they'll usually be coughing and sneezing. And so that's an important step in kind of prevention of spread, really. And usually it's about 14 days to 3 weeks that they have as like a prodromal period. Cool. So Babs is diagnosed with chickenpox. She really wants to go to summer camp. You're the GP, and the mum asks, how long do I have to wait? Do I have to wait? Can she go tomorrow? What would you say? And I think this is one of the key things that comes up in PAEDS, is when kids can go back to school. So it is worth knowing them for a lot of the common infections. Cool.
Just closing the poll now.
Amazing. You guys, you already know your stuff. So yeah, once all the lesions are crusted over is when they can go back. And she doesn't need anything else. You can advise some paracetamol to bring the fevers down. And yeah, that's about it. In kids, we're not too worried. So if we go to the next slide, so yeah, the management. So thing for OSCE is always offer a leaflet, was the big kind of running joke in the year, was offer a leaflet. You can advise them, regarding the scratching, you can give them calamine lotion to reduce it, and also get them to cut their nails, because I'm sure, as I have and a lot of people have, if they scratch them, they scar, and so you're really trying to prevent all that scarring on the child. And then, as I said, paracetamol or Calpol. And why do you not offer a child? Why would you say avoid aspirin? What's the problem with giving aspirin to kids? Does anyone know like the name? Yeah, so it's Ray's syndrome. So Ray's syndrome is like a bit mysterious, but essentially it can cause like encephalopathy and liver problems in kids. So it's completely something to avoid in kids. So yeah, just paracetamol, Calpol. And then you would obviously, in primary care, you would safety net. So if the child deteriorates, if they're not eating and drinking, they've got a really high fever, to come back or to go to A&E. Cool. So Babs is living her best life. She's gone off to her summer camp, and halfway through summer camp, she's got, from where these lesions were, they've kind of gotten a bit worse. And so her mum's brought her back in. And this is the appearance of her lesions now. And so just have a little think about what you might think is going on. And then have a go at naming the rash. Oh yeah, and she's there's oozing of fluid as well from them. Maybe think about what food they resemble. Or even, yeah, if you know the kind of the go-to words for how to describe this rash, you can put that in as well. Or just describe the color. As this is not really something that I think hasn't come up in 4th year. It can happen in adults, but it's just a bit more common in kids.
Okay, we've got a few responses trickling in, but maybe we'll just wait a little bit more to get some more. Just have a pop. Even if you don't know what's going on, just describe what you're seeing.
Yeah, so someone's put in the chat, Sylvia's put in the chat, orange or red papula crusting around the mouth. So yeah, if you don't immediately know what something is, describing it is really good. And don't worry, it's fine that we're on VBox. Let's just see what we've got, James.
Closing now.
Cool. So yeah, macular, crusty, rash on the chin. So yeah, perfect. You're describing where it is. And so this rash is something called impetigo, and it's honey crusted lesions is the kind of classic description of it. It can also be in a bullous form as well, so it can look like kind of honey containing blisters as well in babies. And if this is kind of triggered anything for anyone, I'll give you the causative organism. So it's Staphylococcus aureus. And so in any child who has eczema or any kind of break in the skin, they can get a secondary infection with staph. And so it causes this quite characteristic rash. And so how would we manage a staphylococcal skin infection? Bring leaflets all day, every day. And simple things. You just pop them in the Teams chat. Yeah, so yeah, like definitely we're gonna give someone some antibiotics. We might not give flucloxacillin though, so it's with like any infection, we're kind of looking, is the child systemically unwell or not? Is this what have we tried already? And so for Babs, if she's otherwise kind of all right, we can kind of start off with some more simple measures first. And so we're going to offer mum a leaflet with a smile. And then, so this is a very, very infectious. It's very, very infectious. It's probably why kids get it really, because they just don't wash their hands and things. So we're saying hand washing is key, not sharing towels, washing bedding as well, trying to avoid scratching as well. If they've got any other thing going on like eczema, we want to really get that under control because they'll keep getting this. And then so topical, you can give a topical hydrogen peroxide just to kind of as an antiseptic. You can do topical antibiotics. And then if that didn't work, or it was just a very extensive infection that we were worried about, you can then move on to your oral flucloxacillin for 5 days, and then it's clarithromycin if they're allergic. And you would refer if the child is systemically unwell, if there's, as we know, like staph can cause problems with the kidneys. This is just I think generally like it's just fairly common sense. Like you'd kind of just get a vibe. Is the child unwell? Have they got other coexisting problems that would make them more at risk of not really clearing this? So Babs, she wants to go back to summer camp. She wants to enjoy her forest school time. So when can she go back? Okay, 3 more to go. And I think I don't think be hard on yourself when you get these things wrong, because sometimes they're not completely obvious. Like they seem almost arbitrary. Cool. So we've got a kind of 48 hours after the lesions have crusted over as kind of the front runner. But the correct answer is 48 hours after stopping antibiotics. And so this is very highly infectious. So as you can see kind of before, like they are crusted. So she kind of still is infectious, and it can kind of, those can break off. So really we want to be kind of already having commenced treatment for her to then go back. And yeah, so I think basically it's once treatment's done. I think I've got a little box at the bottom that kind of defines it. Yeah, so it's kind of once they've actually properly healed rather than crusted. I know that's like a bit annoying thing to write, but yeah, basically we'd want them a bit better, and probably antibiotics is the best shout. Okay, so with varicella, the other kind of crossover is with obs-and-gynae. And so I'm probably just going to rattle through this, I think. So one thing to bear in mind with chickenpox is, are there individuals around that child who would be susceptible to getting a very poor infection? So that would be people on chemotherapy, people who have inherited immunodeficiency, but the big one is for year 5 is pregnant women. And so we asked Mrs. Fowler, she's pregnant. She says, oh, yes, I'm expecting a baby. She's been around Babs now for quite a prolonged period, so she's had a significant exposure. She said that she doesn't remember having chickenpox as a child. She's not been vaccinated before. It's important to ask them where they are in the pregnancy, because that can influence whether they are likely to have complications and if the fetus would have complications. And so for her, she's 20 weeks pregnant. And so she is in this kind of big risk category. So there it just says the kind of breakdown. So in the first 28 days, it's fairly minimal, but after that, it can be quite bad. And so there are risks generally to kind of the mother and the fetus as well. So for the pregnant person, it can cause a pneumonia, it can cause liver failure, it can cause a diffuse rash and encephalitis. For fetal development, it can cause congenital abnormalities to the eyes, to the limbs, and these are very, very significant problems. And so they recommend a scan to assess whether this has happened. And then for the neonate, it's generally like problems after birth. So if they catch it in the first few days of life, they can get a pneumonia, they can get the liver failure, kind of like mum, or the pregnant person, and they can get a coagulopathy as well. So it's something to bear in mind, basically. So I think it's always good to kind of split up what you would do for each type of person. So for varicella exposure, it's best to ask, have you had it before? If they've had it before, you're not very worried. Usually people can clear it after that. And so you would just safety net and say, if you develop a rash, come back to us or contact your midwife. If they haven't had it before, and you should always check the antibodies as well. If it's under 10 days since the exposure, you would give IVIG to kind of mop up everything. And then if it's over 10 days, IVIG isn't going to work. And so you kind of just need to see how it plays out. And so you would advise them to contact the midwife if they develop a rash. So let's say Mrs. Fowler does develop a rash. What are we going to do? So the mainstay is antiviral therapy at that point. So IVIG isn't going to cut it. So if she develops a rash, it's going to be oral acyclovir within 24 hours of the rash onset, if they're over 20 weeks gestation, because that's when the problems can occur. And you would consider other measures, so to send into hospital if there were other added comorbidities as well. And so the other thing that I was going to ask, but given the fact that it's 7 o'clock, is you can't vaccinate them when they're pregnant, and that's because it's a live vaccine. So they've kind of missed the boat, as it were. And so that's an important one to ask, because you can kind of fall into the trap of thinking, oh yeah, I should vaccinate them. But you can't do that because it's live. It would be like giving just literally giving them chickenpox. So I think it's also just worth knowing the other live vaccines that you wouldn't give a pregnant person for in obs-and-gynae as well. So yeah, that's the end of that one. And so I think it's always good, whatever your rotation, just go over what you might see in general practice, and we'll do a few more of these cases like throughout the year as well. And just practice describing dermatological conditions. There'll be more to come. I think we'll do a few kind of pictures of the week things as well. And I think just overall, just look at multiple images, and then I think you'll get really, really slick at recognizing rashes as well. And I know that with COVID and things, some of us didn't see actually many rashes on our dermatology placements. So it can be worth just doing that in your own time to get familiar. Cool. So yeah, like thank you very much for coming, guys. The feedback QR code's there. So I added in a whole bunch of stuff this week based on people's feedback from last week. So it is worth doing. If there's anything you don't feel was covered completely, and I did go through quite a few separate bits, and it does take time to get your head around, like we can go back over that again. But yeah, like thank you very much, and enjoy your evening and whatever rotations you're on.